Good afternoon, everyone. Welcome to the second webinar in the series of 3 webinars, which are being co-hosted by Common Health and Kriya. Uh, my name is Alka Barua. I am a pediatrician and a social scientist, and I lead abortion team for Common Health. In the first webinar, we had fascinating and thought-provoking discussions, and this is the second one. And before we go into the actual presentations, I thought I will just sum up of some of the key issues which came up, or the key discussions in the first webinar. The first webinar largely focused on the historical background of criminalization and subsequent legal reforms related to access to abortion in India, and on experiences of other movements for decriminalization, such as that for decriminalization of sex work and homosexuality. In the first session on historical background and legal reforms, Deepika explained the genesis of the Medical Termination of Pregnancy Act and the patriarchal, heteronomical, and eugenic rationale on which it was based rather than on women's rights. But she also highlighted the developments in the last 2 decades, wherein the number of cases in Supreme Court and other courts recognized reproductive rights, choices, and autonomy within the right to privacy and fundamental rights frameworks. She mentioned that the decriminalization of same-sex relation and adultery helped unpack the notion of decriminalization. And all these transformative case laws created a right-based framework for reproductive autonomy and decriminalization. She was followed by Anubha. Anubha spoke about the current legal framework, its expansion, and the impact of these on the conversations around decriminalization. She talked about the increasing number of cases in the Supreme Court and other courts of more than 20 weeks gestation, the criminal liability of self-use, and of non-compliance with stipulated exceptions under the Medical Termination of Pregnancy Act. She, in her presentation, referred to decriminalization in terms of removal of criminal sanctions against those seeking and those providing safe abortion services. She argued that the apprehensions that this notion of decriminalizations raised about coercion and negligence would anyway be subject to legal liability, and abortion should be treated as any other healthcare procedure with standards and norms for care and service delivery. So this was the first session. In the second session on experiences of decriminalization of other groups and movements, Tejasvi elaborated on the complexity involved in decriminalization of sex work, particularly the absence of any space for voluntary sex work, the stigma, the rampant use of anti-trafficking law, the confusion between sex work and trafficking, and the involvement of third-party persons. She talked about how, despite being a movement which predated the LGBTQI movement, complexity of issues and lack or absence of engagement of feminist organizations had adversely affected the efforts of decriminalization of sex work. Arvind, based on their experience of decriminalization of homosexuality, talked about the way struggle against legal provisions have to be framed. He talked about the need to build a campaign around stories and evidence of impact on women's lives, of social and sexual morality that controls, demeans, and subordinates them and the choices they make. He proposed that we need to frame the struggle in a broader sense to change social morality around sexuality and not just talk about decriminalization of Section 312. Webinar 1 also highlighted that despite all these legal reforms and transformative case laws, the continued existence of criminal provisions in the Act contributed to stigma and chilling effect and ultimately to access to services. It is known also from global evidence that legal grounds alone do not help women access services. Access is also impacted by a host of factors at systemic, community, and individual levels. Factors that make women seek and providers provide services often in direct contravention of legal stipulation. And these issues of access are further confounded in situations such as the current pandemic. This webinar therefore looks at implications for access of for access for women in general, vulnerable women in particular, and implications of the health system, public health system, specifically public health system preparedness and public health programs for access to abortion health services. The idea is to identify domains for advocacy. So with this sort of context, we have conceptualized this particular webinar. And the first session is on implications for access to sexual and reproductive health services, specifically abortion services for women and women's rights in health crisis situation as the current one. And our first speaker Shruti Arora is a program manager with the YP Foundation, and her area of work includes training, research, and advocacy in the fields of gender, sexuality, and sexual and reproductive health and rights. And she would be talking specifically from the perspective of young people. Shruti?
Yes, thank you, Dr. Alka. So I'm going to talk a little bit about the implications for health and rights of young people, especially in the crisis and post-crisis situations. Just to give a brief of, understanding young people as a constituency in the country. So when we talk about young people, we need to understand that it is a fluid category, it is not a fixed age group, and definitely the definitions of young people can vary in different contexts and different policies. So for example, UN recognizes youth till the age group of 24, but the national youth policy says till the age group of 29. And in the Indian context, when we look at young people, we include adolescents as well as youth in that age group, ranging from the age group of 10 to 29. Also, just to highlight that India is one of the youngest country in the world right now. 1/3 of India's population is in this age group, and it is definitely not a heterogeneous group. There are huge disparities, social, economic disparities within this age group as well. And the median age of young people in the country is 29. So just to talk a little bit about the challenges in the crisis and post-crisis situation, we had done a series of focus group discussions with young people across the country, and there were a few challenges that were highlighted, especially in the context of SRH that I'm going to talk about, as well as violation of rights of young people. One thing that has clearly emerged from a lot of the conversations is that menstrual health and hygiene is being impacted severely. There is non-availability of sanitary napkins. In a lot of situations, young people are not able to afford sanitary napkins. There are a lot of pockets, even within urban contexts as well as rural contexts, where sanitary napkins are not being available. Then the other thing which remains a barrier in terms of accessing menstrual health and hygiene is that it is mostly the male members in the family who have the mobility to go out, who have the responsibility to go out, purchase ration, etc. And in those scenarios, basically, for young women, getting sanitary napkins become difficult, or it may be difficult for them to have those conversations within families. There is a lot of anxiety that was also sort of talked about, especially in terms of delay in menstrual cycle due to stress or any other reasons. And a lot of young women were not able to understand what exactly is the problem. The other thing is that there has been a lot of surveillance within the household, which covers my point on violation of rights. And there is a lot of restriction, there is a lot of monitoring of who they're speaking with, which are these friends, who they're speaking with on phone calls, etc. In some cases, in Banaras especially, with female students who were, for example, in their third year of college, a lot of them said that there is sudden pressure in the family for them to get married. And because there is uncertain future, there are no job opportunities. Because of that, there is a lot of pressure from the families for them to get married, and that sort of becoming a new norm. uh, then I think in the context of digital safety, there were a lot of conversations that had happened. I think just to sort of say that boys locker room, one example that we've all been hearing about for the last 2-3 days, is an example of toxic masculinity, sexual entitlement that young middle class men grow up with in digital space as well. There is, and otherwise also, there is a lot of normalization of sexist content, jokes, humor within digital space. But I think to understand digital space and digital safety from the perspective of intimacy, pleasure, positive approach as well, there is a lot of concern around privacy, young women's privacy in those conversations with their sexual partners, and for them to affirm their sexual choices. I think now I will go in terms of what is happening with HIV positive people. So we heard from Bombay that a lot of HIV positive people are not able to access ART centers within their cities. A lot of them had to go far away from their homes to access ART so that nobody in their community gets to know about it. And now after the lockdown, they're not being able to go to the ART centers, which has been far away from their home. And especially in a context where the family does not know about the status, it becomes more difficult for them to go. In terms of trans community, a lot of them are not able to access hormonal therapies if they had started their therapy, and not able to access medicines. And this we had heard from Goa, a few cases in Goa, that there is a lack of access to hormonal therapies as well. I think 2-3 important things that have come is that there is very, very difficult situation to access pregnancy testing kits, and a lot of young women are not able to understand if they're pregnant or not. And I think a lot of literature also suggests that young women get to know about their pregnancy at a much later stage, and even if they want to get it aborted, it is mostly after 8 or 9 weeks that they're able to access the healthcare center, and that's been documented, and there is literature on this. I think just in terms of 2-3 things that I wanted to sort of discuss even in the webinar series ahead is that we definitely know that there is going to be an upsurge in the need of second trimester abortions once the lockdown eases out and the situation gets better. So we need to think about post-crisis situation from that understanding that there are going to be a lot of women needing abortion post 20 weeks of gestational period, and what should be our response in those situations. The other thing that I wanted to highlight in the context of adolescent sexuality as well as access to SRH services for young people below the age group of 18, mandatory reporting within POCSO has really been antithetical to the idea of seeking SRH services confidentially. And I think Anubha talked a bit about that. She presented some case studies also in the last session. And I think we need to think more and more from that perspective, especially in the decriminalization framework. We know that POCSO is used in cases of sexual abuse, but also mandatory reporting is really detrimental to young women's access, not just abortion, but also HIV and other SRH services. So I think we really need to think a little bit about mandatory reporting and what can be done in terms of advocacy. One experience that I can share from our work is that we've been working with the adolescent department in the Ministry of Health and Family Welfare, and every time we try to advocate on this point, we hear that Ministry of Law and Justice is the correct institution to address this. And I think if you're talking about decriminalization of abortion, we really need to think about this and think about POCSO and mandatory reporting as a clause within POCSO. So I think I will end over here, and if there are any other questions that I can take up, then happy to do that.
Thank you, Shruti. You, in fact, finished before time. We'll take the questions at the end of our three presentations, if that's okay with everyone. Since Manisha is back, perhaps Manisha can do her presentation. Manisha, can you hear?
Yeah, I can.
To reintroduce Manisha, as I said, she doesn't need introduction as such, but she has been part of women's and health rights movement in India since 1970s and is the co-founder of Mazoom, a rural women's organization with headquarters in Pune. Over to you, Manisha.
What I'm going to do is I'm going to backtrack a little bit, and I'm going to talk of the one system actually that does not allow us access even in so-called normal times and exacerbates in human-made or natural calamities, one that we're going on now. Here I want to say that, abortion is very much body linked. It's linked to the uterus. So it's not like Brahminical patriarchy that plays out on my body, have a bath before you cook for the rest of the family. And the bath is upon my body because I may have had sex with my husband. But really, it's Brahminical patriarchy playing out of my body. What I'm trying to present here is that it's actually related to the uterus. So anyone who has a uterus, women, trans men, uh, can need an abortion sometime in their lives, could need an abortion sometime in their lives. Now, just imagine that if all these uteri got unionized or got collectivized, it would be a very big blow to patriarchy. And so, therefore, each uterus then gets divided specifically. So, what do they get divided on? The system that divides our uteri is the patriarchal institution of marriage. And so, therefore, like you wear the marriage signs, so therefore, then do you have access to contraception? Do you have access to abortion if you are widowed, or you left your husband has left you? Why do you even need contraception or abortion? Whose seed is it? Mera bacha mara, that is what the husband does, the drama outside, or it wasn't mine, that's why you aborted the fetus. When a sex worker was kicked on her stomach in Satara, and she said, please don't kick me on my stomach, I'm pregnant. The police officer says, Randi kabhi maa nahi ban sakti. So, which uterus, which person, which fetus are worthy of life and which are not worthy of life, who can have an abortion, why they can have an abortion, where, by whom, for what reasons, and when. I think these become the hallmarks of patriarchy, and then what we see as similarities or even sometimes discordant manifestations actually are not that unrelated. So, for example, somebody who has HIV or somebody who is a sex worker might not be considered worthy to be a mother, and so therefore then abortion might actually become more accessible to her if after she faces all the stigma and after she faces all the humiliation. Similarly, for a woman living with disabilities, if she's not even sexual, how did she get pregnant? And in 1994, when we took up the issue of hysterectomies of girls in a state-run institution in Maharashtra, the girls were as young as 13, 14, and the oldest was about 34, 35. What had happened was that one of them had got pregnant. Somebody had died of tuberculosis, somebody had fallen in a gutter, somebody had died of gastroenteritis. And now the 17 girls were brought to Sassoon Hospital. And then we campaigned against that. Ms. Anand Phadke and I, and then IDWA also joined the campaign. So Medico Friends Circle was part of that campaign. And the whole question was, how did they even get pregnant? So why did hysterectomy become the answer for the pregnancy? One is to deal with menstruation, and two is to deal with rape and sexual abuse. So what might seem, actually not connected with each other are actually connected because of the institution of patriarchy. And then how the family, the community, the market, and the state are institutions of inequality, and how they perpetuate discrimination, inequality, and disenfranchisement, both in the public and the private spheres. So I'm going to talk about CEDAW in a few seconds here and right at the end. So CEDAW in Article 1, that's the Convention on the Elimination of All Forms of Discrimination Against Women. It's a UN treaty, 1979. And it says that any inclusion, exclusion, any act, whether direct or indirect, whether intended or unintended, has the consequence of denying people the ability to be exercised and enjoy all their human rights at all times, is discrimination. And so therefore in patriarchy you would find that certain women are excluded from abortion and certain women are specifically included. So it's like including Jewish people to before the Holocaust, or even Muslims in India at this point, so that you can justify lynching or a genocide. So even specific inclusion with the intention or lack of intention, but of course here it's clear intention. So even inclusion actually can be a form of in discrimination. Now, things that we see independently. I'm just trying to going to link them all to patriarchy. So technology centered, failure of contraception. Now, if we want to link failure of contraception as a reason why patriarchy doesn't allow an abortion if it's not related to failure of contraception, because in the sexual act there was a man involved, and so if it wasn't wanted at that time, then the man had some say in that. But if it was wanted at that time by either or both parties, and later on the woman goes and has an abortion, the man is outside the equation. And so therefore you cannot say that yes, it was wanted at that time, but situations changed and I don't want it at this particular time. So therefore technology also is linked to patriarchy. Now if we see legal, obviously we know the state is also an institution of patriarchy. It can through laws also challenge patriarchy to some extent. But if we look at some of the recent judgments, one is that it makes it provider control. The second recent judgments about a sex worker requiring an abortion was that obviously a sex worker would not want the abortion, and the whole conflation of sex work and trafficking. Then also an abortion that happens before marriage then becomes grievous physical or mental harm, and then the girl has to file rape on the boyfriend or the husband or the lover that we know. So why would an abortion outside of marriage become grievous mental or physical harm? It's a socially constructed issue of when a pregnancy is allowed and when a pregnancy is not allowed. And so again, that is also linked to abortion. The corollary means that a pregnancy inside of marriage is always wanted. And I think that is what we have to challenge here. Now we know that medicine as an institution that perpetuates inequality. If we read the Glass Mountain pamphlets of Barbara Ehrenreich, Deirdre English, etc., we know that medicine, especially OB-GYN, came on the backs of women health workers who were abortionists, who provided contraception, even who actually conducted childbirth. And so therefore that kind of medicine is also linked to patriarchy. And so therefore we know that it happened over women's bodies and happened actually with the whole lynching and killing of witches. Now fetus centered, anomaly, abnormality, whatever we want to talk, is that why are women who have female fetuses targeted by at the time of abortion? Women who have male fetuses have gone home. They don't come under the scanner of the state. And so therefore, again, patriarchy scans and confronts women who have female fetuses, but lets those women who have male fetuses go there. If this is a problem, then that is equally a problem. The community we know and the family, that it's all honor-centered. They want sons. There's a threat of bigamy or desertion for women. There are economic and other priorities. Marriage is a punishment if you've had sex earlier. And now let's go to stigma in the community, whether it's COVID-19 or whether it's abortion. Why is there a stigma for these two? It's a stigma for these two because stigma exists in society for other things, like Erving Goffman would say. And so therefore today people won't go to test for COVID-19 because it's stigmatized. And women have to go as far as possible to have an abortion at the cost of quality of care just to get confidentiality. So in the last 1 or 2 minutes, I'm going to say that all that we saw, where is it woman-centered? How to make it woman-centered, how to strengthen our public health services, how to challenge the neoliberal globalization that is going to make education and healthcare much more expensive. And therefore, in all these uncertainties, whether it's COVID-19 or whether it's neoliberal globalization, where child and early marriage are going to become the norm, are going to become the first response of families. I think that the answer, and obviously all of us think the answer to this is to make abortion a right, irrespective of reason, and state accountability to women rather than vice versa. And here again, I would go to CEDAW, which would be my last point. The three pillars of CEDAW: one is non-discrimination, the second is state obligation to respect, protect, fulfill, and promote rights. The woman is the rights holder and the state is the duty bearer, and substantive equality to make the playing field equal for all women who require abortion at any time in their life. I think that this is something that we need to do, strengthen public health services. I would again reiterate that, and look very closely at the institution of heteronormative patriarchal marriage. Thank you very much.
Thank you, Manisha. Shampa. Shampa Sengupta would be presenting. She will be speaking on implications for access to sexual and reproductive health services and rights of people with disabilities in health, particularly in health crisis situations as the current one. Shampa Sengupta is an activist with more than 3 decades experience of working on disability and gender rights. And she is the founder of Sruti Disability Rights Center and serves as the Joint Secretary of National Platform for the Rights of the Disabled. Shampa, over to you.
Firstly, thanks to the organizers, because bringing in the issue of disability within the discourse, which actually we do not talk much about disability when we're talking about abortion. This is something which we need to understand is one of the main reasons behind that is the common understanding of being a person with disability is often accepted as considered as a minor person. I mean, it's like one of my lawyer used to say that they're perpetual minors. So they always need guardians. So they are never like grown up. Disabled people are never grown up people. So abortion, sexual and reproductive rights are usually not something which we talk about when we are talking about disability. And thank you, Manisha, for bringing in the perspective of the Pune case that happened. Hysterectomy of women with disabilities is actually very common thing, and it does not only happen within institution. Institution means government-run institutions, which we usually call homes. It actually happens in homes, within families a lot more. Large number of family members say that they do not. They cannot control menstruation periods of women, so that's why they want to actually do the hysterectomy thing. And very few actually, I mean, some mothers actually confided to us that they think that it's very difficult for them to stop this their children, either adolescent or young woman, being raped within family system, and they are so nervous that their child might become pregnant, and that is the reason they want to do hysterectomy. So there is a long history of hysterectomy and disabled women. This story we all are aware of. Interestingly, if we look at abortion laws, the MTP Act, it talks about it doesn't talk about legal capacity, but it says someone who can give consent. Now, who can give consent is a big question within disability movement. Also, there are different kinds of voices, particularly parents of children and adults with intellectual disability have a different viewpoint. People who are disabled themselves have a different viewpoints. So these are the issues which we all need to put in the background when we think of. I'll talk a little about the Rights of Persons with Disabilities Act, which is a law that came to us after much fight, and we I think at least the disability movement think it's a major shift in the it's a paradigm shift, we call it. It's the earlier law was totally charity based, but the present law that we have is more our current law is more rights based. That's what we talk about. I'll just talk a little bit about how even in this law we have contradictions. One thing it is very important to understand also that disability is not a monolithic idea. I mean, it's like there are different kinds of disabilities, and when we talk about hysterectomy, we usually talk about women who are either intellectually disabled or psychosocial disabled. So they have some kind of mental illness or mental health issue, whatever the term we like to use. But when you go to the ground, actually, a lot of women who are visually impaired said that their families actually wanted their the hysterectomy to be done to them. They also didn't think that because this girl will never get married, so never. It's better to do away with chances of her becoming pregnant. And these kind of issues which we used to discuss quite a lot before RPD Act was enacted. I'll just read out two clauses from RPD Act. From the RPD Act 2016, the reproductive rights says, the appropriate government shall ensure that persons with disabilities have access to appropriate information regarding reproductive and family planning. Second clause in this under reproductive right is, no person with disability shall be subject to any medical procedure which leads to infertility without his or her free and informed consent. These two clauses are something very interesting. One thing is, as we can see, it talks about his and her. So there is some kind of gender neutrality which they tried to bring in, though they didn't mention, of course, that transgender people are not included in the RPD Act. But this is something really, I think, which we need to think of why when we're talking about reproductive rights of disabled people, we're talking also about male disabled, which is usually not mentioned in the, again, reproductive rights discourse. But what I want to talk to here about is about talking about without his or her free and informed consent. Now, who will give information to a disabled person? Whose role is it? Is it the state's role? Is the family's role? We don't know. I mean, it's of course the state's role, but do we have any accessible information? Where it's the whole disability movement is actually depends on the NGOs, so to say, and so it's every information. So suppose there is a say morning after pill kind of thing. Is that information accessible to a person with disability? How will she know that this is a pill I'm supposed to take after so many hours of having sex? How will she know? Is a packet in the which these pills are sold, do they have accessible information? Is there any braille inscribed in those packets? We don't see anything like that. What about our condom packets? Do we have, are those accessible? I mean, accessibility is a huge thing. It's just not only talking about ramps, which we usually talk about whenever we talk about disabilities. Wheelchair access is something that always comes about. What about the TV ads that comes? Do our TV ads are coming with information detail where a hearing impaired person can also get all the information. We don't see those kind of things. And so and it's very important to understand that accessible information is one of the vital thing that a disabled person needs, and particularly in a situation during COVID, when we have seen that we have a guideline, we have a central government guideline that talks about that the information regarding COVID should be accessible. Initially, there was only the Kerala government who could bring out sign language interpretation with all the this thing. It's only, I think, just last week we saw there was from Assam, they've got it. So there are few states they are bringing it out. Again, it's important to understand that disability is a state issue. So it depends on how a state is dealing with a particular situation. So, and it's not everything, we do not depend on the central government. Though this law is actually made by the central government, but the implementation depends on the state. So during COVID also, we are seeing this whole scenario that's happening right now for us is most of the disability groups are actually working on relief because people down in the at the ground level, they are not getting food. So we are not even thinking of talking about any other rights. Right to get food is not being fulfilled, and most disability groups are totally now becoming instead of talking about any rights, we are actually looking after relief work. So we are actually trying to procure rice and are making plans how to give it to disabled people. That's the whole thing that's happening in COVID situation, and it's very few number of disabled people can access any kind of information at any point of time. And now this COVID situation, actually, I think we are now going back to the charity model. I'll come back to the RPD Act. Sorry for getting diverted a little bit, but the situation right now is so difficult for all of us who are working in this field, because we keep on thinking that how to bring 2 squares meal to the members of our network, and that is something which comes to our mind throughout the day. I'm just coming back to the RPD Act. We have a section on punishment, and it says who will get punished. It talks about the clause is 92F, which says a person who performs, conducts, or directs any medical procedure to be performed on a woman with disability, which leads to or is likely to lead to termination of pregnancy without her express consent, except in cases where medical procedure for termination of pregnancy is done in severe cases of disability and with the opinion of a registered medical practitioner, and also with the consent of the guardian of the woman with disability. Now, this is really something, a very difficult clause of the law, which at the ground level, we don't know how to actually implement this. It says that a person will be punished if you take any medical procedure leading termination of pregnancy without her express consent. But then it again talks about if it can be done for someone who's got severe disability with the opinion of registered medical practitioner. Now, how can this, this itself is a self-contradictory clause, and it also talks about consent of a guardian of the woman. So you have decided from the beginning that there will be some disabled women who will have guardians, and some disabled women who will not have guardians. It's a very difficult situation where how do you understand who, in which case. This is not, of course, not explained in the law. So when we go to the ground level, we are not sure how this clause can be implemented. It can be misused. it can be used in any kind of manner, particularly the guardians. We have seen that we have, in the beginning of my talk, I just said that it's many of the families actually want women with disabilities, that they wanted the hysterectomy to be done. So now this thing is some the guardian can want that. And who will be the guardian? Again, the family members. So if there is a rape case happening, and there's something which is very sad, because majority of the cases that we dealt with, of the particularly women with intellectual disability and some with hearing impairment also, we came to know of those cases only when the girl actually becomes pregnant. You don't even come to know of that rape happened. And rape, it was not a rape that was happening only once or twice, only once. It's like serial rapes happen, and only when the girl becomes pregnant, the family comes to know. Only then the whole case, we as case workers come to know, as social activists, and we get to know. And do we really have a position? Because the law is contradictory, as I said. Like, I'd like to end my presentation with the Suchita Srivastava case, which was very much talked about, very much discussed in the context of abortion and disability, because it went to Supreme Court. Of course, the Supreme Court judgment, I find it very flawed for me. Though the girl herself got the right to keep a child, the abortion was not done, and she's now happily having a child. But the whole legal wording says, they are saying because she's not mentally ill, but she's mentally retarded, so she can have her child. So you are making again a gradation of who can keep a child, who cannot keep a child. And it also talks about the law. If you see the judgment, it also says that she can keep a child because child does not have anomalies, and which is totally against the whole disability rights movement, where we think that every fetus with any kind of abnormality also the right to be born. And it's a very complex issue, this disability and abortion. I think particularly because we are going through this COVID-19 phase right now.
Champa, can we sort of wrap it up so that we have more time for discussion?
Yes, I'm just, this is my last sentence. Because now we are again re-examining survival of fittest. And this COVID-19 situation throughout the world has got that term back to our mind right now. And abortion and disability, this whole complex issue, is something which we need to think from that angle always. Thanks.
Thank you, Champa. Do people have questions? They can sort of type those in the chat box. For any of the three presenters, any clarifications or questions or any points you want to make? So Agatha, you had made some point about what's happening in Karnataka, particularly related to menstrual hygiene. Would you like to say something about it?
Yeah, I just wanted to share about the distribution efforts with respect to sanitary napkins, because I think when that effort was undertaken, initially napkins were given, but then it was being realized that the women and the girls were not using them because they were not used to it. And of course, waste disposal during lockdown was in the initial days a huge challenge. So there are quite a few sustainable menstrual groups working on in that area, and an app was created to then connect the community to other sustainable options, and the distribution of say menstrual cups or reusable cloth pads. So I just wanted to make that point.
Yeah. Aparna, you had raised your hand. Would you like to come in?
Yeah, I had a question to Suti and others who are working with youth-based organizations. Is there any discussion happening around the age of consent for sexual activity bit in POCSO? I mean, in the abortion, as in SRHR circles, we talk about mandatory reporting quite a bit. But unless we deal with the age of consent issue, any sexual activity under the age of 18 will remain criminalized, and therefore, consensual sexual activity and consequent SRHR needs and requirements will keep getting suppressed. So I'm wondering if there's any discussion happening at the policy level on this. I mean, I can't imagine this government doing much, but is there some discussion happening? And I just wanted to say on the disability question that we really need to do an audit of the MTP Act and the very problematic distinctions that it makes between who's a mentally ill person and a mentally retarded person, who needs consent, whose guardian needs consent, and also just the whole eugenics framework. The act itself says that it has been brought in for a eugenics purpose, which is forcing women to adopt the language of eugenics in order to secure their right to abortion. So just an audit of the MTP Act from that perspective, I think, is very essential to any of our advocacy strategies going forward.
Would you like to respond, Shruti?
Yes, sure. So I think there are 2-3 things. One is definitely that the age of consent was 16 before POCSO came in. And, if we want to think through about that what should be the age of consent and what do we think is the age of consent, and how do we then advocate for, say, legal change on that. I think in terms of doing advocacy with the government, we have really at least from the Ministry of Health, it has mostly been dismissal and, just passing the buck that this is not our arena and we cannot do much about that. So that's been their response. We've been giving recommendations in terms of, at least passing a guideline or letting health facilities know that, if there is a consensual case that you get, then you need to address that immediately without any getting involved in any MLC process, informing the police, family members, etc. So we've been giving that recommendation to them, but I think nothing much has changed. Nothing has really moved on that front.
Yeah, Shampa, before you respond, there is another question from Sundari. Sundari, would you like to ask your question?
No, I wanted to hear from Shampa of 1 or 2 examples of the kind of challenges in accessing safe abortion because of living with a disability, meaning discrimination by the health care providers and so on. So.
I think the major issue is the whole medical fraternity actually do not consider disabled woman is someone who's as someone who's, again, like which I started with, as a person. So you're always a minor. So you're always a minor. So you always have usually you talk to a guardian, and the guardian have to take decision whether you want to have abortion or not.
Rupsa, you had some question?
One is, I think, this whole issue of legal capacity that I think Shampa raised is, I think, something very important for us to consider, because I think to the extent, the disability movement has kind of really looked at the issue of legal capacity, with a lot of nuance and with a lot of thinking. And we see that reflected, for example, in the UN Convention on the Rights of Persons with Disabilities, to some extent, but not fully reflected in the Rights of Persons with Disabilities Act in India. I feel like, to some extent, I think we who've been doing the work on advancing safe abortion and abortion rights haven't really looked at, and of course it shows up as this one clause in the MTP Act, but behind that there is a lot of complexity, and I think it's worth us kind of trying to interrogate that framework a little more. And there's much we can learn from the disability movement's articulation of what legal capacity should look like. And the second thing I was going to say is, to some extent, it links to also this whole question that even Aparna was asking about young people. I mean, we do think a lot about, below 18, the kind of denials we see for abortion. And so again, this whole thing of guardianship regimes, the kind of substitute decision making that often laws allow rather than granting individuals rights is, I think, something worth discussing. And my second point was actually something that I'll come back to later when we have the advocacy discussion that Subhashri will guide, which is a bit linked to the second trimester abortion. So I'll stop here.
Related to your question about services to adolescents and the influence of POCSO Act, I think Swagata has posted something. Swagata, would you like to talk about it too?
Yeah, sure. Along with mandatory reporting, I think one also needs to look at, the abetment provision under POCSO, which has, if one looks at it very strictly, it would hinder even the provision of any information that would then, lead to an adolescent experimenting with sex, or, even advice on what are the safe ways of having sex could technically fall under that abetment provision. And the other point that I wanted to highlight is that in some states, it has also affected the access of, adolescent, pregnant women, girls to maternal benefits, prenatal benefits that the state is offering, because the minute they register for the benefit, it would mean that a POCSO case would have to be filed against their husbands. This is in the context of Tamil Nadu, which has this program called PICNI, and one has to register under it. All pregnancies, irrespective of whether it's going to be a private hospital birth or government hospital birth, have to be registered on it. And the minute they get your age, it would mean that, if you're below 18, it has to be a POCSO case. So many girls have had to drop out of that program, and therefore being denied of the benefits that is available, which they certainly need, because it would mean filing a case against their husband or their boyfriend.
Thank you, Swagata. Subhashri has a question. Part of it is going to be covered in the next session, but nevertheless, it is applicable here also. So, Subhashri, please go ahead.
Yeah, so I had two things. I mean, this whole discussion around POCSO itself, but the government also runs the whole USH program, which itself is supposed to be giving information, provision of contraceptives. So it's all very contradictory. So what the legal framework says, what program says. So there's a lot of contradiction and conflation there. So, but the point for which I raised my hand was regarding abortion services within the in this current COVID situation and the lockdown. We all know access to essential health services, a whole range of essential health services has been affected because of mobility restrictions. But the situation of abortion is particularly unique in the sense of the whole, the whole gatekeeping that's involved in especially young women needing abortion services. All of the government's responses, including the Delhi High Court judgment, for which Sama had gone to Delhi High Court and got some orders on how access to care for pregnant women can be facilitated, which talks about, the field healthcare worker keeping in touch with the pregnant woman, ambulances being arranged, helplines being set up, etc. Are not particularly appropriate for the situation of a woman who wants to seek abortion, especially when she wants to keep it extremely confidential. For example, if it's outside of marriage. I was contacted for two cases, one in Delhi and one in Bombay, where young women who were now stuck with their own families in the situation of lockdown, but were pregnant, needed an abortion service, could not tell anyone at home about it, could not actually leave the house, because you have to then explain why you need to leave the house to seek service. So I think it's a particularly unique situation, and I do take the point of Shruti that second trimester abortions are going to increase, but also what do we do currently to facilitate this access, and how do we actually advocate for it? I think it's something that urgently needs to be done.
Thank you, Subhashri. Any other questions? Does anybody want to ask anything of the three speakers or has any comment?
I think I just want to add one point to what Subhashri was saying, that, in the COVID situation, the other thing about abortion and the unique situation that we are in is also that abortion pills are not available, and abortion pills are also not under essential drugs. So I think that is also one sort of thing that we need to look at.
Since there are no further questions, I think we'll move on to the second session. Thank you, Manisha, Shruti, and Shampa. The next session is on implications of public system preparedness and programs for access to abortion services, particularly in the context of the current pandemic. The first speaker in this session is Vinod Menon. Vinod is the Chief Executive Officer of IPAS Development Fund in India. He has more than 2 decades of program management experience and has particular interest in strengthening the evidence base and health system capacity for abortion and contraceptive care. Vinod is going to speak specifically on the public health system preparedness. Over to you, Vinod.
Hi, good afternoon, probably good evening. I was just thinking one of the biggest personal impact of COVID-19 is it has clearly made my internal clock, completely changed it up. So I already feel like it's 6 o'clock in the evening. Thanks for having me here. So I thought, in terms of talking about this, when this subject came in, as many of you may know, IDF primarily works with state governments in trying to improve abortion services and contraception services in many states. So when just after COVID and after lockdown, we try to get data on what's happening to both abortion services and contraception services in our geographies that we work in. So we had collected data from around 500 plus sites in 8 states. So I thought that was primarily meant for internal use, but I thought it kind of would be relevant to the topic that was given to me to talk today. So I thought I'll run you over some of the broad findings that we had of the SNAP survey. Next slide, please. So this is probably, today it is COVID and it's at a large extent, but any kind of if it's a pandemic or any kind of a emergency which is out of the ordinary could have similar effects. So probably it's a lesson that we need to learn, and including health systems and the government, on how do we prepare ourselves, insulate ourselves better. So one of the broad implications would be the supply side implications in the public sector. If you look at the current time, almost 30% of the medical colleges have been converted to COVID care. That means they are completely dedicated to COVID care. Similarly, about 6% of district hospitals, SDH. But in addition to this, what happens is many of the district hospitals, sub-district hospitals, and some CHCs, in addition to these numbers, a certain number of beds have been repurposed for COVID. Therefore, what happens is in all these facilities, then COVID-19 care becomes primary and everything else gets secondary to that. And quite often, the facility staff and the infrastructure there is just not able to adjust and keep the other services which they were earlier doing ongoing. And similarly, also the other impact is you have a vast number of staff redeployment where both providers, nursing staffs are deployed to higher level facilities where they are focused on COVID. So primarily what happens is about, on an average, about 1/4 of your health force is completely removed from the other tasks that they have to do because they need to be primarily focused on COVID. Next one, please. Then and this is primarily about lockout and the ability to think. Two things have been happening. If you look at it, 89% of the facilities reported a decrease in outpatient footfall. And about 2 out of the 5 that is about 200 of the facilities that we surveyed, mentioned that there is a more than 80% reduction in footfall. What was impacting this is two. One is the men and women's ability to reach the facility. And the second is there were many of these facilities had indicated that they would be stopping certain of the outpatient OPD treatments. So this reduction is primarily both from the ability to reach facilities as well as the willingness of public health facilities. Rather than willingness, I would like to say the ability, the capacities in which the public health facilities will be able to provide the services, given the huge demand and stress that COVID has placed on all across the public health system. Yeah. Next one, please. So where does both these, the supply factors as well as the access factors, where are they impacting abortion services? 78% of the 500 facilities reported a decrease in service, and half of them reported more than 50% reduction in services. So if you really look at it, that is pretty significant reduction in abortion services. And if you map it against contraception services, and I mean here all contraception, as many of you know, both IUCD, that's interval IUCD, and sterilization, the government has got a guidelines out that they're not going to provide them during this period. I understand that there's going to be a change in the guidelines, but as of now, both these are not being provided, while postpartum is still being provided. So given that, but if you really look at all contraception, and we were looking at all contraception services, because these times, at least even if substitute contraception is available, that meets the need to a certain level. About 84%, so it's very similar patterns. 80 plus facilities reported, and 2/5 of them reported a greater than 50% reduction. Having said this, yes, it is a matter of concern, because as somebody mentioned in the earlier session, we are going to be looking at higher number of unwanted pregnancies and definitely an increase in second trimester abortions. And we know as a country, both in the public sector and in the private sector, our ability to provide second trimester induced abortions is very poor. So these are going to be some of the impact. But at the same time, I do think that it is a good case to say that public sector, despite all the constraints, there is still in many places services are continued to be available. The other challenges, and I think I wanted to talk about what would happen in the next few weeks. My anticipation is, our prediction is, things would slightly improve in terms of facility-based services. But the larger base, now when we look at abortion, we all know that 73% of abortion happen outside the facility. So what is happening to medical abortion within, at the pharmacy level? So as a separate exercise, we at IDF are trying to do a modeling exercise to determine impact of COVID on abortion, the whole ecosystem, looking at both public, private, and outside facilities. So the data that we have got currently indicate there is about a 40% decrease in medical abortion uptake at the chemist level. But one of the concerns and the hypothesis in which we approached this issue was, what's going to happen in 2 months' time, 3 months' time? Because many of you may also have seen newspaper reports saying, import of the ingredients, the active pharmaceutical ingredients, IPIs, for various drug categories may get impacted because many of them come from China. But what has been reassuring is, at least the experts here whom we met with, both in the public as well as in the private industry, that means the SMOs who are doing MA drug marketing, as well as some of the private players, they do not anticipate the API's shortage to disturb MA supplies. So things may get better, because till now, what is happening is, from the company to the distributor, and from the distributor to the retail chemist, supplies were getting interrupted, which, given the new relaxations, there would be slightly better supply chain flow. But the worry is not about India, the pharma industry as such, not having the active pharmaceutical ingredients to go on to manufacture MA drugs. So that doesn't seem to be a concern. So that's a slight good news. Similarly, even in the public sector, at least in the states that we are working in, you see the budgeting of medical abortion drugs have already been done. And about 50% of the states, the ROPs, that is the sanctioned budgets, have already been implemented. And our sense, our knowledge on at least the states that we work in, is there is a pretty adequate number of MA available for services to continue. The only problem is going to be the problem that I talked about. Will the facilities be open to providing services, and will there be enough providers to deliver? But from a supply chain problem, I don't think MA is going to be a problem, both in the public and in the private. I think that's it. Thanks.
Thank you, Vinoj. We move on to a presentation on the public health program, implications of that for access to health services. The presentation is by Kalpana Apte. Kalpana Apte is the Secretary General of Family Planning Association of India. She has more than 2 decades experience in planning and implementing clinic and community-based interventions that deliver health, especially sexual and reproductive health services. Over to you, Kalpana.
Thank you, Alka. Thank you for having me here and the discussion around access to abortion. When you gave me this topic, I was thinking, and I really have been thinking, that what is it which has changed really in COVID? We know what all has changed. Essentially, all the programs, first of all, let me say that there isn't any national level, or even to my knowledge, there isn't any specific state level program which talks about abortion, just as we would have for family planning or other programs. There isn't any such program that addresses the access to abortion, or that tries to work around ease of access or awareness. So I don't see that there is any such programs, though there are activities within the ROPs, that is at the state level budgets of the program budgets of the states, there are activities to support abortion services, and that's a different discussion. But then there isn't really a coherent, well-rounded program. So that is that. So if we look at that, I think what is it that has really changed? And the situation on the ground, Vinoj has already told you how things have changed, and I completely echo what he has shared, and he has shared it very mildly. I think the situation is even more serious at the ground level. It's not only abortion, but since this discussion is about abortion services, I think I can just mention that also family planning services are equally seriously hit. Having said that, what about access to abortion and then private? Because we know that most of abortion services are provided through private sector, be it the access to medication abortion through pharmacies, or provision of services within the clinics of doctors, MBAs, MMAs, and so on. And a small percent would be through the public sector. And we know now how badly the public sector is coping, trying to cope up. It is hit badly. It is trying to cope up with the COVID crisis. And genuinely, they are not able to provide services. I mean, I don't know genuinely or not, but I'm just trying to understand and say, okay, yes, case numbers are very, very high in many areas. And in green districts, and I have some information on that, even there, access to services because of the lockdown has been extremely difficult. Because now let us look at how women are able to move towards the service delivery, and how women are able to access services or not. So let me tell you, women are not able to come up to any service delivery point. And also there is enough and more data to say that even accessing medication abortion through chemists was also done significantly by their male counterparts. And women, fewer women rather than men were coming to the pharmacies to access medication abortion pills. Saying that, I mean, this is the second in the series, and we've spoken quite a lot. I mean, I've heard a lot last meeting, this meeting as well. There have been since afternoon discussions around women's autonomy and their decision agency to access abortion services. And more than a program, I would just like to speak why there isn't, and also what does it mean. There's 146 districts in the country have a very specific family planning program. Thank God it doesn't have monies for promoting abortions. I mean, I'm saying it with irony, okay? Because for almost every service, women are being paid some kind of travel amount, or there are some kind of, and there is a lot of discussion around that. Really speaking, coming from a perspective of an organization that provides services to the most marginalized and poor, vulnerable groups of women in this service, I can say that it is one of the most stigmatized service in the entire system. It is something that a woman who comes to access services, be it public sector or be it even providers, it is something that it's the fault of the woman. It has taken a lot of investments, training, and orientation for us to see that our providers do realize, and a lot of other providers who we train do realize, rights-based perspective around providing services to women. And therefore, I really don't see that there could be a program of government of India that coherently, programmatically has strategies or outlines which supports women accessing abortion. Because it stems from the very basic fact that women's there is not much understanding or respect for women's autonomy to access service, even if it is not understood from in any case in India, health is not even understood to be a right. So I'm coming from that perspective, and I'm saying that, okay, it's not understood to be a rights perspective, but even if it is understood a health perspective, that, okay, it's a women's health issue, then also I don't see that kind of change or acceptance happening for a very long time in the programmatic way. So this is where I am at. I would also like to address a couple of things which were discussed earlier, and also there's some questions around, I can see in the chat column, I can see some of the issues that have been raised. And that is one cantankerous. Already the abortion access has been very narrow, very straight-jacketed, narrow, very difficult, subject to interpretation, and it is almost extremely difficult. Within that, now we have even more stringent POXO Act, which actually makes it illegal to provide services to a girl below 18 years, married, unmarried, unless the provider has ensured that the police are informed. Knowing our country's cultural background, knowing how people will react, almost about 70%, I would say, and I don't have the data at hand, but that's my understanding, beyond 60%, 60 to 70% girls, when we inform them that we have to inform the police, actually leave without accessing the services. And that is really a travesty, because these are the girls who really need it. We have a white paper on what is the impact of POXO on all other SRH services. Really speaking, there is a question that isn't it an abetment? And yes, it is actually. All RKSK program itself, which talks about giving information or even condoms to young people, actually this is an abatement, because you are giving a condom to a young person with an intent that he may use it. So that is a reality. There is this. However, we all know that married and unmarried young people have a complete different pathways to access to services, and particularly for abortion. So we are at that level. When the lockdown lifts up, then also women are not going to be easily able to come to access abortion. The cultural stigma at home and out of home is extremely difficult. the system support that was there, that an ASHA worker was taking, or there was an accompanied referral at times. Now it is going to be even more difficult because of social distancing and restrictions on how many people can. An ASHA doesn't get any money for bringing an abortion client to a service delivery point. If it is private, probably she may, but otherwise not. So she would classically collect a few people, a sterilization case, a pregnant woman, and so on, and she'll bring 3-4 women actually. Now it's very easy to guess that from a remote rural area, a woman will get left behind because ASHA will not be able to take more than a designated number of people post lockdown and when the threat of COVID is around us. So there are going to be many points. Poverty, I've been saying that poverty is going to increase in India. The poverty line is going to now substantially shift, and many people are going to come below poverty level. And therefore, we know what women sell, and we know what women take loans to access an abortion service. And we know how women are, and actually young girl is the face of poverty in India, we know that. So, and we know that women are also the face of poverty. And we know that how this poverty will then reflect on access to. So I have spoken from this perspective, from a woman's, and bringing it together with the systems that are already there. And I see that in coming times, we really will need to work hard, and we need to provide some kind of solutions or policy direction to the government for the stronger policy, so that women can at least come to the centers. At least they can come to the centers and access services. And this last point that I wanted to speak is about the private providers. There is a need for us to strengthen, and I don't know how, it's a difficult one, but I keep coming back to that. And then private providers have so much of resistance, difficulty, genuinely also they are jailed, we know that. And there are so many. And I just stop here, and I will just stop here.
Are there any questions? Kalpana, I had one question.
Yes, please.
Not necessarily related to this COVID situation, but what is your view about and your experience about the emphasis on post-abortion family planning, particularly in the Mission Parivar Vikas districts, how it has impacted access?
So yes, well, absolutely, it's not only in Mission Parivar Vikas districts. Let me say that it is not even new. This is something that has been there for decades. We all know that when we were training, and we know that, I mean, almost everywhere, a woman who goes to a public sector facility for abortion, it's almost necessary. And in those days when it was surgical more than the medication, definitely it was conditional. We know there have been papers written on that. So it is there, but since there is, so let me say it in this way, since there is a number game for family planning, right? And that number game means that you would, as a provider or as a person who needs to fulfill a particular number, who you would utilize, that's number one, you will utilize every avenue to get that one woman in, and you will have a value judgment on her decision that you already have 2 children, 3 children, 4 children, and why should you do that. Then you will have another value judgment that, okay, oral pills or condoms are not to be trusted, and a long-term method or a sterilization is the only method, that because it's a provider initiated method, right? So it comes from multiple kind of biases, and it comes from that historical perspective that's already there. It's the travesty of family planning program in our country. And the last thing which really gets my goat is that people say that if you had a good family planning program, then you would not have MTPs. When I have never heard such an utter bakwas in my life. And even there are people who are at higher levels, and those people who exist in policy making bodies, and very well read and well educated people also keep saying that. So that's there. It seems as if MTP is a problem and family planning is a solution, to say that.
Vinod had some point. Vinod, you have your hand up.
Two things. One is, Kalpana, I think I totally agree with your passion that you don't really connect the family planning to as saying if you provide family planning, we should reduce abortion by providing family planning and the reverse, because it leads to a lot of stigma. But
Yes.
Alka, to your question on this whole private-public sector contraception, let me throw some data here. We do hear about this compulsion, right? We do hear, and we all know that there was that providers say that we would provide abortion only if you have a sterilization or a long-term reversible contraception. But in the 11 states that we worked in, last year, for example, I think there were about 150,000 women who got abortion services, induced abortion services, out of which post-abortion contraception is only about 70%, which is including condoms and OCPs. If you look at IUCDs, it's around 12%, ranging from about 4% in Assam to about 16% in Karnataka, but overall 12%. So it's not that there is so therefore, the data doesn't present to the fact that that there is a lot of compulsion that women need to get a contraception, what do you call it, a long-term reversible or a permanent contraception before abortion, or that abortion gets tied in. And one of the reasons for this is also because why it's so low is the provider who provides abortion services is often a doctor, but IUCD providers are often nurses, and that sync is not there. So that could be also another reason. But therefore, I would be slightly hesitant to make a judgment that there is a strong push to make abortion conditional to an contraception acceptance.
Thank you. Any other questions? If no one has any question, then we'll move on to the next presentation, next session. Thank you, Binosh. Thank you, Kalpana. The next presentation is on implications of the recent amendment to the MTP Act for access even beyond COVID, not just in the current situation. The presentation is by Dr. Suchitra Dalvi. Suchitra is a practicing gynecologist and coordinator of the Asia Safe Abortion Partnership. She's a member of Common Health and is on the board of Inroads, an international network for reduction of abortion discrimination and stigma. And we have to mention it that she also contributed to the conceptualization of this series of 3 webinars. And since I'm thanking Suchitra, acknowledging Suchitra, I should also acknowledge the contribution of Shreya and Sonaksha. Shreya is documenting this entire series, and Sonaksha is doing the graphic recording for these series. We just wanted to sort of mention this before we move on. Suchitra, over to you.
Yeah, hi, thank you so much, Alka. And yes, I will just move on to my presentation. And today I'm going to take you through a little bit of an analysis of the implications of the MTP Act amendment for access even beyond the pandemic. So when we start looking at what the amendments mean, some questions need to be asked really, because as we've been discussing so far, we've got the Indian Penal Code, we've got the Medical Termination of Pregnancy Act of 1971. So how are these amendments going to be different? Do the proposed amendments bring about a shift in power from the doctor, healthcare provider to the persons who do not want to continue the pregnancy? Do they increase women's autonomy and agency? Do the amendments decriminalize abortion? Do they ensure that no woman is turned away or forced into an unsafe abortion or into continuing a pregnancy that is unwanted? Some other questions we would like answered are, do they increase public sector access and government accountability? Do they improve private sector regulation? Do they provide for better access to medical abortion pills? Do they ensure that all government hospitals are providing the full range of services, including second trimester abortions, and without any coercion for contraception? So as you can guess from the way that I have positioned these questions, the answer to all of them is no. So one really has to wonder, what is the purpose of these amendments? It reminds one of the Red Queen in Alice, who says it takes all the running you can do to keep in the same place. And that is the same kind of feel one gets after, going into the details and unpacking the amendments really. So what do the amendments say? There are some specific points which are positive. The original framing which spoke of the contraceptive failure by married woman or her husband has been reframed to say by any woman or her partner. Although, it being 2020, one could actually make even better progress and say person or their partner and say pregnant person instead of pregnant woman. It's interesting to see that the rationale has been accepted as, continued, that the anguish caused by such pregnancy may be presumed to constitute a grave injury to the mental health of the pregnant woman or the pregnant person. And in a sense, this really gives you a basis to move towards a rights-based approach, but the amendments don't really reach that point yet. One more proposed amendment, which is in a sense progressive, is to enhance the upper gestational limit from 20 to 24 weeks. However, they have said that this will only be for special categories of women, which will be defined in the amendments to the MTP rules and would include vulnerable women, such as survivors of rape, victims of incest, and other vulnerable women like differently abled women, minors, etc. So this again makes one wonder, very much a needs-based, very much a kind of a victim, let's rescue the victim kind of an approach, not really rights-based. What about the other vulnerable populations? Like how exhaustive is this list going to be? Is it going to include tribal women, migrant workers, displaced persons, victims of intimate partner violence, institutionalized women and girls, child brides, trans men? So really speaking, if it is feasible to do an abortion beyond 20 weeks for a certain group of people, then why isn't it okay to just do it for everyone up to 24 weeks? So that's something, which one needs to really question. The preamble to this amendment says very clearly that the MTP Amendment Bill 2020 is for expanding access of women to safe and legal abortion services on therapeutic, eugenic, humanitarian or social grounds. So that again makes one wonder what really is left anymore. Once you've covered all these grounds, who is it that you're going to be able to leave out and say, no, sorry, you are not eligible for having a safe and legal abortion service? And that brings to mind something that Manisha Gupte says often. These may not be her exact words, but I'm hoping to capture the spirit of what she says, is that some women are not allowed to choose to continue, while others cannot choose to terminate. It is easier to offer sympathy to a woman who was forced to have sex. Society is unable to forgive a woman who chose to have sex, especially the wrong kind of sex. So, whether it is before marriage or outside of marriage, etc. This is the woman who is to receive social punishment by being forced to continue or to die trying to terminate. So when one really looks at the entire range, like therapeutic, eugenic, humanitarian, or social, who really is possible to be left out of this particular range? In which case, why don't they actually go all out and make it a rights-based approach? But we are not nowhere close to that in the amendments. And here I would like to refer to what I call the gestational age circus. When I unpacked the fact that there are different rules for every few weeks of gestation, there's the inner circle of up to 20 weeks. Then you've got the 20 to 24 weeks, 24 to 40 weeks, because 40 weeks is kind of the, the full term delivery. And anytime if an emergency such as the woman's life is in danger. So the current MTP Act says that up to 12 weeks, you need the approval of one single provider. But from 12 to 20 weeks, you need a second provider to approve. Now, this is a very strange, the only one of its kind legally mandated second opinion that a medical provider needs to take for a procedure which isn't even that much more complicated, because as we will see, from 20 to 40 weeks, it's that same single gynecologist who's going to take the decisions of terminating the pregnancy if the life is in danger, and also handle any complications at the time of delivery when the fetus is, almost double the size of what you're dealing with at 12 to 20 weeks. They're going to deal with eclampsia, emergency cesarean section, obstetric hysterectomy, everything. So suddenly, why is that second opinion required between 12 to 20 weeks? It doesn't make any sense. Whose benefit is it for? Now, what the proposed amendments do is they say, okay, only a single provider is required up to 20 weeks. So that's great. That's an improvement on the current act. But again, suddenly you've got the second person required between 20 to 24 weeks. I mean, that's like such a narrow window within which suddenly a second opinion is required, and you really have to wonder why. But then the amendment goes one step further and says if it's between 24 to 40 weeks, you in fact need an entire medical board, which will have not just another gynecologist, but a radiologist, a pediatrician, etc., etc. So now suddenly the opinion of this first gynecologist, who was fine up to 20 weeks, the second gynecologist who was brought in for up to 24 weeks, neither of them have any valid opinion at this point, but a completely third gynecologist who's on the medical board, including some 4 or 5 other practitioners, are going to opine on whether, the substantial fetal abnormality in a sense deserves to have the termination. This is in violation of all human rights requirements because it brings in not only a third party, it brings in a fourth, fifth, sixth, seventh party to a decision which actually should be a private matter between the woman and the gynecologist. So it kind of reminded me of this really bizarre, like a game show almost, you know, like if it's up to 12 weeks, it's fine if you do it on your own. 12 to 20 weeks, you need to phone a friend. So the second gynecologist needs to come in. If it's beyond 24 weeks, currently people are going to court getting a 50-50 decision on the matter. And the weirdest thing is when you have to go to a medical board, because it really is like the audience voting in on the KBC. They can vote anything they want. And you know, the person who's taking their opinion is affected by the judgment, but the people who are giving the opinion are not affected by it at all. So how in this scenario is it supposed to be acceptable in terms of the woman's autonomy, agency, and the right to decide what to do with her own body? So it's literally like, you know, kya aap abortion karana chahte hain? Like it's one game, like a whole host of people are going to be involved in the decision. And again, coming back to the same story, only one OBGYN is required by this same person for any other emergency, some of which are completely life-threatening, like a postpartum hemorrhage, managing eclampsia, doing a cesarean section, you know, obstructed labor, obstetric hysterectomy, etc. So what really is the purpose of having this medical board brought in for an abortion when you don't require it for a full-term delivery, which is, you know, far more dangerous and requires a much larger fetus to be delivered out and much more blood flow. So one really wonders if there is a sliding scale of the value and values and rights that are underpinning these recommendations. It seems as though with increasing gestational age, you know, the value of the pregnant person or the agency goes on reducing, whereas a sort of greater weightage or value is given to what happens to the fetus as a result of which. And that is something which I think is a very serious matter, which really needs to make us pause and think, because, you know, this is kind of a slippery slope towards giving personhood to the fetus, and we definitely don't want to be going down that road. And willingness to extend the limit of the termination. So beyond 24 weeks, when this medical board is going to approve, it's basically beyond the limit of viability. So it signals an acceptance of a procedure that would essentially require stopping the fetal heart inside the uterus, or what is actually called feticide, before terminating the pregnancy. But if that can be done for a fetus with certain anomalies, then why not for all late-term pregnancies that the woman does not wish to give birth to? So again, a lot of you know, questions unanswered in terms of certain steps that have been taken with the amendments. What are the abortion facts in India? Most women are married and seek abortions to limit the size of their family. Other common reasons are poverty, to increase the spacing between births, or to protect their health in cases where underlying medical conditions would be worsened by pregnancy or childbirth. Among married adolescents obtaining abortions in Maharashtra, more than half reported having an abortion because their previous child was too young. So one can only imagine how early the childbearing is starting among these young girls. Delays in recognizing pregnancy are another reason. Limited information, unsuccessful initial attempts using traditional methods, stigma and fear, poverty, and limited access to services are all reasons for second trimester abortions. The Guttmacher study report of 2017, as we know, gave us some kind of an estimate based on a multi-state study. And they indicated that 15.6 million abortions are taking place in India, only 22% of which were obtained in health facilities. And as we can see from this pie chart, the vast majority were medical abortion, and most of them were obtained outside health facilities. So perhaps the time has come to legitimize what is clearly already a practice in the country, and potentially push for an increasing role of telemedicine and even self-managed abortions. However, the amendments, as we can see, don't actually address any of these. So the real question to ask is, are we really ready for women's right to safe abortion in India? What is the environment within which we are advocating for this as a right? We've got the Bombay High Court judgment, which in 2016 passed a landmark judgment recognizing the absolute right of women to abortion. They said that the woman alone should have the right to control her own body, fertility, and motherhood choices. Then we had the Supreme Court judgment, which, as part of the right to privacy, which they said is a fundamental right of every Indian citizen, they said that a woman's freedom of choice, whether to bear a child or abort her pregnancy, are areas which fall in the realm of pregnancy, of privacy. Now look at this judgment and look at the medical board, which has 6 completely random people who are going to, you know, sort of stand in judgment on this woman and take a decision whether the pregnancy should be continued or not. Of course, we are also in an environment where, you know, when marital rape was asked to be criminalized, the Indian government said that men would suffer if that happens. So, we are kind of not even allowing women the right to say no to sex within marriage. But they can't even say yes to abortion. So it's a very strange position that we put them in. We also have the PCPNDT Act, which bans prenatal sex determination. It does not say anything about what one does after that. So a woman who has found out that she's pregnant with a male fetus and goes home and continues the pregnancy is also guilty under the Act. This is a sex selection of, who to choose to give birth to. However, the entire implementation and the rhetoric only talks about sex selection through abortion, and therefore doubles the stigma on abortion, while not addressing the actual root cause of sex determination, which is gender discrimination in the first place. So this is, the Beti Bachao, Beti Padhao campaign, which we are all aware of. Again, ostensibly to save the girl child, which again is a very paternalistic and sort of victimhood kind of a narrative, not really improving her agency. But again, you can see that within their own narrative, they've conflated PCPNDT and MTP. So it says conducting PCPNDT/MTP raids, conduct of PCPNDT/MTP court cases. And if you look at the images on the right side, it talks about curbing sex-selective abortion, again missing out on the whole range of sex-selective births. It talks about changing the mindset of people and promoting girls' education. But nowhere does it actually talk about empowering or giving the women agency, because the promoting of education is only, again, very utilitarian, so that she's able to help the children with the homework, or at least wait till she's 18 and finishes school, then, she can marry soon after that. So this is the kind of environment in which we are talking about. Again, we have these posters and the rhetoric, as I said, this says, if you kill daughters, where will you find brides? So in the struggle to improve the sex ratio in terms of, numbers, we're losing sight of the fact that the reason why people don't want to have girls is because women are a secondary citizen in our society. They are an economic liability, whether it is because one has to pay dowry or whether it is because they are not able to, work and earn the same way as men can. But here we are asking for them to be born so that they can marry these boys in order to, again, reinforce the patriarchy. So it's really bizarre, that we're coming at it not from a solution, but again from the same environment of the problem. Selective abortions are accepted or even normalized in a sense for ensuring an able-bodied child, as we saw from the preamble to the amendments when they talk about eugenics and setting up this whole medical board to allow terminations for fetal anomalies. So if selective abortions are accepted for that, why not for a male child? And philosophically, aren't all abortions really selective? Because you're selecting out of the normal obstetric trajectory going towards a delivery. But we don't often have, spaces or have these conversations which, give us a big picture or a bird's eye view of where our advocacy is coming from. So as we can see, it's very difficult to work on one issue without working on the others because they're all wheels within wheels. People nowadays want to have a small family by choice, but women want the right to control their body. Within the patriarchy, women are not able to say yes to contraception, not able to say no to sex, but they can't even say yes to abortion if you restrict the access in such a way. So in all this confusion, it's very difficult to just pick and choose and say we're going to work only on choice or we're going to work only on contraception because they are all interconnected. Here is a case study I would like to present it's from Chandigarh. So it's from a developed area. It's recent, from 2017. And I would just like you to think of the amendments proposed and see whether this particular woman will be helped at all by what is being proposed. A woman was employed as a housemaid. This was her 6th pregnancy. So she has 1 son, 2 daughters, and 2 induced abortions. Her husband remains opposed to the use of contraception. Initially, she sought an MTP through a government hospital, but was denied because of procedural delays. What were these? They asked for an ultrasound, which is not really required by protocol. The ultrasound she wasn't able to get because she didn't have an Aadhaar card, which again is not required by any protocol. So finally, she ended up taking abortion pills from an unqualified private physician and ended up at the government hospital to seek treatment for bleeding. At this point also, although the patient was eligible for tubectomy, her husband was uncooperative. And here again is the patriarchal controls on women. The wife's consent is not required for the man to have a vasectomy, but the husband's consent is required for the woman to have a tubectomy. And as the authors have very rightly, given the title to their case study, so near yet so far. Access to safe abortion services remains elusive for poor women in India. And as we reflect on what the amendments are proposing, she's not going to be helped by any of these, in any of these barriers that she faced. So in the post-pandemic world, what are we looking at? There's likely to be an increased cost at all clinics, whether in the NGO sector, definitely in the private sector, because COVID-19 testing is going to be required. The test itself costs many thousands of rupees. If she requires a surgical abortion, then an entire team, so the surgeon, an assistant, maybe a nurse, the anesthetist, they would all require to be wearing personal protective equipment, and that cost needs to be borne by someone. So if it's not going to be underwritten by either the donor or some other way of finding the costs, it's going to be handed over to, the client is going to have to pay for that. Many people have lost jobs and livelihood, hence people are actually becoming poorer. There will be an increase in the need for more expensive types of abortions, like the surgical and the second trimester, due to lockdown delays where women have not been able to reach the service delivery centers. And thus the gap between what people can afford and what the abortion is going to cost is going to expand quite radically. There will be an increase in unsafe abortions because many people will not be able to reach clinical facilities. They will get desperate, particularly as the pregnancy grows and becomes visible and obvious. There are likely to be shortages of contraception as well as medical abortion pills. Here is an FRHSI policy brief which they came out with recently, which talks about the impact of COVID-19 on India's family planning program. In the best case scenario, they say more than 24 million couples will not be able to access contraceptives, which will result in an additional almost 2 million unintended pregnancies and more than 1 million abortions, including 681,000 unsafe abortions, which, as we can imagine, they are just estimates. The numbers are likely to be more. The numbers are likely to be more in areas where, there is even less access to healthcare facilities in the first place. So unless we shift the socio-cultural patriarchal underpinnings of the rationale to control women's reproduction as a compulsory and unpaid reproductive labor, and women's role as permanently consenting sexual partners within the framework of matrimony, it is difficult to move beyond laws which are paternalistic. We need to locate our advocacy within the gender and sexuality politics. If we are to be able to move towards abortion as a right of the pregnant person over their own body without any conditions. And maybe, as Arundhati Roy has said, this pandemic could then be a portal to a new world of our creation. Thank you.
Thank you, Suchitra. Any questions? So if there are no questions, I think we will request Subhasri to take over the next session. Dr. Subhasri Balakrishnan is a gynecologist with long experience of working with Rural Women's Social Education Center, RUSEC, a grassroots women's organization working on reproductive health and rights issues in Kanchipuram district of Tamil Nadu. She's a member of Common Health Steering Committee, and she would try to sort of pull together all the discussions that happened together today. And over to you, Subhasri.
Okay, thanks Alka, and thanks everyone. I hope I'm audible. It's been a very, very interesting discussion, and I think I will not spend too much time summing up. I would like to open this out. Have a lot of time for discussion rather than what I want to say. But just a couple of things that I wanted to put forward. One is, of course, it's very clear that there are. We talked a lot about the legal framework last week and the issues with the framing of the law, and then also how the law and how it acts out on the ground also prove as barriers. And also Suchitra has just now highlighted how even the recent amendments do not very much change the framing of the law itself. But apart from that, two broad areas in which we have seen barriers on the ground. One is, of course, the whole health systems issue, which seems to be accentuated by by the current COVID pandemic, both in ways, both in the way in which the pandemic is being framed by the health system, and therefore resources taken away from other essential health services for COVID, and then a very in a sense inevitable overwhelming of the health system by the issues caused by the pandemic itself. we've also, so apart from the health system issue, we've also talked a lot about, and both Manisha and then now Suchitra have spoken a lot, also Kalpana, about how the whole gender and patriarchy, that acts at multiple levels, including at the individual, family, household level, at societal level, but also at the health system level, which didn't come up very much in the discussions about attitudes of providers, and how that is framed by the whole gender and patriarchal values that they have ingrained in them, to act as a barrier to access to abortion. We also had both Shruti and Champa coming in with the issues of specific groups of persons with disability and also of young people. We also had some discussion about the COVID itself and what it has done to what it has done currently to access to abortion, and what it is likely to do once, even when the pandemic kind of subsides, or when the lockdown is opened, what it's likely to do to access to abortion. So I was asked to specifically facilitate this session on what does this then mean. I mean, if these are the range of issues that we have, what does this mean in terms of planning our advocacy? And Manisha actually ended with ended her talk with a few pointers towards this. And just to recap, a few things that she said was, I mean, if you want, was one, of course, the whole immediate thing of looking at what COVID itself is doing, and second, of looking at what we need to do in terms of advocacy with the health system itself. But I think a much broader area that has been discussed over and again in these 2 hours is about how gender and patriarchy and the whole framing, how the influence of gender and patriarchy and the whole body and sexuality politics on how the law is framed, how services are framed, how programs are framed, then leads to issues with access. So I will stop with that and open this out to see what we see as ways forward in terms of, how as a group who are looking at increasing access to safe abortion with all of these issues, and maybe take on some of the issues from last week also, as the issues of the legal, what we need to do in terms of the law, and then also in terms of what we are seeing as other barriers, and what would be issues for advocacy, both in the immediate term and in the long term, and any ideas on how to move forward.
Subhasri, Aparna has added another question to it regarding the revision of the national population policy and introduction of population control measures and the impact that could have on SRHR. So perhaps that also needs to be included.
Yeah. So Aparna, would you like to come in on that?
Yeah, no, I was just asking, there seems to be increased chatter from the government. Yeah, and Rupsa mentioned in his Independence Day speech, the Prime Minister also mentioned, introducing population control measures. And it is, if I'm not mistaken, part of the government's manifesto as well. But regardless, so the point is, are we, is there any specific move? Are we seeing any specific move towards some population control measures at a national level? We know that there are population control measures at the state level. They've been upheld by the Supreme Court very problematically. But are we seeing anything at the national level? And what might be the implications of that for unsafe abortions, coerced abortions and unsafe abortions? And should we in our advocacy try and factor that in and sort of get out ahead of that policy coming into place and build in advocacy strategies around it? That is the question.
Okay, thanks, Aparna. So does anyone want to come in on that?
Hello, this is Kalpana. Can I try to address this question?
Yeah, go ahead, Kalpana.
Yeah, so thank you for this question, Aparna. This is really something that has had us worried for some time now. I'm a member of, FPA India is a member of ARC, that is the Advocating Reproductive Choices Coalition. We work on, this is something which is coming up quite seriously. There are 2 private members still in the parliament asking for 2-child family norm. And we haven't yet heard so much about the population policy being kind of rewritten to include that. But we know that the parliament has those 2 private. Now we know that private members' bills they are not very likely to be made into the taken forward. However, this is something very serious. So there is a whole set of very concentrated and structured advocacy that is happening at this moment, writing to the government, and we have been in touch with the Ministry of Health and Family Welfare, where the officials were very clear that they didn't have any such thing in their mind to follow this kind of two-child family norm. However, it is a policy matter and it's not a bureaucracy that is going to decide the policy. Bureaucracy will have to, at some point of time, agree to that kind of policy. So the technocrats within the ministry were quite clear that this se to nahi ho sakta, aisa kaise hoga ye sab. So this is the situation. It is a real threat. It is a real problem, and there's a whole set of advocacy happening, and if you wanted to, I could share some of the details over email with you.
Yeah, thanks, Kalpana. Does anyone else? Manisha, I see your hand up. So, do you want to come in?
Yeah, can you hear me?
Yeah.
Okay. So, whether the discussion is happening at the state or national level, at the implementation level, for years we have seen that women who have more than 2 children cannot stand for any political office. The third child's name is not entered into the ration cards, and there is no maternity leave. I mean, what, if it weren't so tragic, it would be laughable, because over 90% of women are in the informal sector anyway, and among that, we don't even know how many get maternity benefits. Rather than universalize that, you're taking away from those who have maternity benefits, and then taking away economic rights, that is, say, for example, through ration cards or political rights, is a gross violation of human rights. And it takes us to the quintessential Marx-Malthus debate about whether poverty is the result of overpopulation or the cause of overpopulation. And if we agree that poverty is not the cause of overpopulation, then we know that we know that overpopulation is not the cause of poverty, but that poverty is the cause of overpopulation. Then taking away from the poorest, whose children are more likely to die, and to take them disenfranchise them from economic and political rights, I think is a gross violation that we need to address. And this is happening irrespective of whether this law comes at this central level or not. Thank you.
Yeah, thanks, Manisha. I can see Alka and Sundari's hand up. So maybe Alka first and then Sundari.
Yeah, I just wanted to know how we bring in FOGSI in this entire advocacy related to access to safe abortion. Recently, Suchitra and I attended a webinar organized by FOGSI, where they talked about how MTP is an excellent act for empowerment and protection of doctors. So as long as that view exists of a very important and powerful stakeholder, what kind of advocacy efforts are required to correct the situation?
Yeah, so maybe we'll hear from Sundari also, and then we'll see if anyone wants to respond to your question on FOGSI specifically. Sundari?
Yeah, 2 points. One is an aside, which is about the population control measures are not even evidence-based, and there are only 3 states of India that have above replacement level fertility, and the vast majority of the states have below replacement level or at replacement level fertility. So I don't know. I think the second point is that these are not 2 separate advocacy issues in my mind. If we frame, and I really like what Suchitra said about that, this whole thing has to be framed within the discourse of gender and gender discrimination and sexual politics and control over women's sexuality, then population control is another dimension of it. Saying you cannot have children, saying you can have children, or you cannot terminate the pregnancy, therefore you should have a child. These are all parts of the same framing of women's right to control, for control over their bodies. So maybe, I would really like to hear from others that, I mean, what do they see as the feasibility of an advocacy campaign that, frames it in this way?
Yeah. Thanks, Sundari. So, does anyone want to come in on? I mean, on one, of course. I think Alka's question on Foxy is also very related to this, because how we frame the issue, and this was discussed last week also, when the importance of framing your issue for a particular campaign, if you're looking at decriminalization as a possible campaign objective for us, was brought out by Arvind. And I think it is very important that we frame it in this, I mean, in this macro of bringing in the gender and sexuality politics that actually drive both the law and the policy and programs on the ground. So how do we move forward? I see Suchitra's hand up. Manisha, do you want to come in on another one, or is your hand raised from earlier? Maybe Suchitra, you can start.
Yeah, hi. So just to come in on the point that Alka mentioned about Foxy, for those on this group who don't know, that when the last time the amendments were being proposed, which also included the task shifting proposal, which would allow service providers beyond just the OBGYN who are allowed by the Act currently to also come in as service providers, there was a lot of opposition from Foxy, as well as the Indian Medical Association. And even this webinar that Alka is referring to, a lot of the conversations were around wanting to have stricter controls on medical abortion pills, sort of complaining that women are taking the pills and then coming up with complications. So I think the whole concept of self-managed abortion needs to be really understood from the perspective of these mostly private providers, and how they can actually end up being far greater barriers to the kind of issues that we are talking about. Particularly, as I said, if people haven't really understood that pushing for the gestational age limit beyond 20 weeks means that you have to do a feticide in order to ensure that a non-live birth takes place, then I have a feeling a lot of these OBGYN doctors who are not in that sense pro-choice, they are going to be very, very difficult to deal with. So I'm not really sure what kind of role Foxy can play. Foxy is not really, it can't ensure anything. It's just a membership body. It's more for, people collectively doing conferences and CMEs and things. They're not really a regulatory body. So we can bring them in. We should bring them in probably. But I'm not sure how much they can influence in the so-called rank and file, even if the office bearers may be supportive and in agreement with our perspectives.
Yeah, but they are a very visible group with voice, so that I think becomes an important issue. So I can see Dr. Manisha Malhotra's hand up, and then Vinod. Dr. Manisha?
Just to elaborate a little bit on Suchitra's point, that let us not malign Foxy so much. See, they have been pretty supportive in the past even for the mid-level providers, and of course for the fetal issue they would be. But it's only, because of the change in leadership which happens over time, and then, other influences on them like IMA and political influences, that the stance has slightly changed over the last few years. So I mean, with good advocacy, we can bring them on board, at the appropriate forum and time. Thank you.
Vinod?
Again, I was taking over where Suchitra and Manisha left. I think all of us have a big lesson to learn about the amendment process and how the mid-level providers got torpedoed purely by the medical community. Similarly, if you're going to talk about decriminalization, promoting self-use of abortion, I do think it's necessary that we start socializing the idea with the regular doctors, the regular rank and file members of Foxy. Because irrespective of how much the Foxy leadership believes something, at the end of it, what we've learned is the mass rank and file members can torpedo an idea. Therefore, I think we as an external group, if you're moving toward decriminalization conversation, making self-use as a definite option for, recognizing the self-use, which is already an option, then we may have to look at how do we socialize the idea, how do we get them to accept it rather than this fear they are having, this huge fear they have about women using drugs.
Okay, so does anyone else want to come in on any ideas about how do we move forward on the advocacy? I see some messages here from Kalpana and Aparna and Dr. Manisha Malhotra on the two-child norm bill. Do any of you want to talk about it?
I can speak a few things about this two-child family norm, and I absolutely agree with Sundari that if it comes, it is then disaster waiting to happen vis-a-vis MTP access. However, at this moment, see, these two-child family norm at the state level for being eligible to fight an panchayat election has been there for a very long time in many states. And recently in Rajasthan also, some hundreds of panchayat members were, I think they were removed or they were made illegal. Now the problem is that it is going to be a broader set of disincentives are going to come if this member, and this bill is being introduced not only in upper house by one Mr. Rakesh Sinha, who's a very influential person. He's part of the think tank of the present PM, and also by a Shiv Sena MP in the Rajya Sabha. So you can imagine that the similar kind of thing coming from both sides. So you can just imagine that how this momentum is gathering. And it is a very, very worrisome thing. And it's not an abortion advocacy. And I really think we need to think through the language, even talking about abortion and family planning and population control. I think it's a landmine. And therefore, it has to be from the perspective of family planning and not really from abortion, because then we will have another fist actually coming at the access to abortion, because it will suddenly become a dirty word, even more than dirtier than it is already in some people's mind. I think there is an advocacy, but that's a different piece of advocacy, and we should have a broader advocacy group there. Another point that I was thinking, that when we are talking of access to safe abortions and decriminalization, we cannot but talk about advocacy around consent, reducing the age from 18 to 16 and POCSO. Without that, nothing is going to happen. I think if we are talking of advocacy, that is one piece that we will need to start now, and it will take about 2, 3, 4, 5 years, God only knows how many, before we can get to POCSO amendment. So that's where I will stop.
Yeah. Rupsa?
I had an earlier point and then a new one. So one link to what Kalpana and others are saying around the two-child norm already it's there, as is widely known at the state level in various ways. But the other thing is that, of course, the census is delayed, but it's going to happen. And there is a danger that even though, of course, we know there is replacement level, many states have reached replacement levels of fertility. The truth is, when it's disaggregated, and we know the way it is disaggregated, and this whole thing around the Hindu birth rate and the Muslim, etc. So I think there's a real danger in who gets left out, and we know those who are the margins are the ones who will pay the price for a two-child norm, the greatest, as Manisha rightly pointed out. But I wanted to come back to something vis-a-vis the MTP amendment, and since we're discussing advocacy, I know we don't have enough evidence yet, but we know that abortion, people who need abortions are facing delays, and we are anticipating an increase, as has been flagged by many of the participants, in terms of second trimester or later abortions. And I feel it creates a real conundrum for us, all of us who've been advocating to kind of urging the government to relook the current MTP amendment, because the truth is that amendment, amongst one of the provisions is to increase the limit to 24 weeks. And the worry now is that if the idea that there have been all these delays in seeking abortions and larger numbers of women need later term abortions could become a way to rationalize that, we need to urgently pass this law. So I'm just raising it. It's not fully clear in my head, but as I was seeing all the comments, and I know we've been thinking about the MTP amendments quite deeply in this larger group. So I just wanted to flag it, and I don't know if there's any, we could always come back to it during the next webinar, but I just wanted to put it out there that do we need to rethink even our advocacy on the MPP amendments, and what sort of arguments do we put forth?
Yeah, thanks, Ruksa. I see that we just have a minute left. I mean, we're already over time. So does anyone quickly want to come in on the MTP amendment that Ruksa talked about? Else we will park that for further discussions in the next webinar. Yeah, Renu's also specifically saying that there are other areas within the MTP Act that need to be unpacked. We've talked about, you know, the whole legal capacity guardianship issue also. So Renu, do you want to quickly comment on that?
So, I think that our discussions over the last 4 hours have been very wide ranging, and I think that's great because we are expanding our horizons, and we still have next week to go. But I think the challenge is to really sort of narrow down on what are we advocating for and to whom. Because FOGSI, to my mind, we're not really advocating to FOGSI, for instance. FOGSI may at best be influencers, if at all. And I think the discussions that we are having on this whole thing about mindsets, which becomes a much, much, much larger issue. The patriarchal control of women's bodies and sexuality, all of this is a much larger issue. And within this frame is what we have to define our advocacy issue. From what Arvind was also talking about last week, it seemed that a much larger sort of sensitization, education, talking, to remove the taboos and to remove the stigma around sexuality, around gender discrimination. So a lot of societal level discourse is required. So my point is that within these larger wide-ranging discussions, we have to narrow down and focus on what our advocacy issue is.
Okay, on that note, I think I don't see any other hands up and we are already beyond 4:15. So I think, Alka, should I hand it over back to you to close?
Yeah, thank you, Subhashri. I think we overshot by 15 minutes and there are still more than 30 people around, so that shows the level of interest in these webinars. Now we have the last one on 13th, next Wednesday, and we expect that all of you would join. We in any case would send a reminder a day before the webinar. So thank you very much everyone for participating. Thank you.